perfectionist in you, but it is more so that you can focus on the basic things. You should not miss out on the commoner things because that's where you lose the race. So I have come up with a mixed bag which is full of spotters, starting from breast imaging to fluoroscopic imaging, and then will be followed with the cross-sectional imaging, which will comprise of the gynecological as well as the few spotters of fetal imaging. So I'll be giving you almost half a minute for each spotter, and we'll take it in bundles of like 15 or 10 spotters, and then we'll discuss it one by one. But spotters will be discussed very briefly because it will be followed by OSCEs where we have to give a major time. So I hope everybody is ready for the session. There's a chat box.
Yes, ma'am, we can start now.
Okay. Okay. So section A will comprise of the breast imaging. This is the first photo. Just to help you out, I have magnified the image. This is the first spotter itself. Now this is the second spotter. A and B, mammography and ultrasound images of second spotter. The third spotter. This is a fourth spotter, and in fourth spotter, it is I'm giving you two images. This is 4A. It can be of the same pathology or it can be different also. That we'll discuss later. This is 4B. Now this is the fifth spotter. Spotter number 6. Quarter number 7. Quarter number 8. Number 9. Quarter 10A. This is 10B. Quarter number 11. Quarter number 12. This is 13A. There are two spotters in, there are two images in spotter number 13. I have to give diagnosis for each of them, either separately or can be of the same pathology. 13B. Is 14th. Number 15. So this first bundle was majorly for breast imaging. We'll look up to the answers now. What do you think was the first spotter? I cannot see the chat box.
It is just adjacent to the sharing option.
Okay, fine. Mhm. Yes. So AT and B, okay, all have nicknames. So most of you have guessed it right. It's lipoma. How about the second spotter? Second spotter, can anyone? Second is galactosele. We can see a fluid level and there is layering present. So this is a galactosele. So why not an abscess? Radio Sapien is asking. So see, first of all, you can see this is encapsulated and there is not surrounding edema, which is by which we usually diagnose an abscess. This is looking like an encapsulated lesion and there is no surrounding edema. So abscess is very less likely in this image. Next is, what is this? Hamartoma. Very good, Rahul. Why hamartoma? It is consisting of both fat as well as soft tissue density interspersed with each other. Okay, now who has got this correct? What do you think this is? So there were two sections in this, like this is 4A. Any guess? It's a benign condition, right? Yeah. So basically it is ductal. There you are correct to some extent. It is ductal and it is ductal ectasia. These are just dilated ducts. And yeah, it can be DCIS also. We'll have to do FNSE in this. We cannot differentiate. And how about this spotter? Is it similar or something else? Do you think there is some architectural distortion? There are speculated margins. What can it be? So it came out to be sclerosing adenosis. But what BIRADS will we give it? We have to give it BIRADS 4. The reason being we cannot differentiate this on imaging with carcinoma. So we have to do a biopsy to rule out. Only few of the things are there to differentiate. Like there is no mass as such by which we can call it a carcinoma. But again, architectural distortion and speculated margin, definitely we have to give it BIRADS 4 and then we can downgrade it later on. Okay, how about this? This is a calcified vessel, Mondor's disease, Rahul. Very good. So what is Mondor disease? It is, so we can see it is confined to the subcutaneous plane and it is a thrombosuperficial vein which is calcified. One more thing you need to know, that what is the most common site? Upper outer quadrant of the breast is the most common location. Okay, and it is a painful condition, but it is self-limiting. How about this? So, as I told you in the beginning, you don't have to come up with very big diagnosis. Sometimes it is very vague and miscellaneous, like extensive secretory calcification. So you have to first think about the common conditions and then come up to major ones. Okay, now what do you think this is? Is it confined to the skin subcutaneous plane or is it parenchymal? Rahul, very good. It is dermatomyositis. It is confined to the subcutaneous plane. So I think most of you must have got this right. Large, smooth marginated. What is it? It's a phylloids, Rahul. Very good. And what bireps do you give to phylloids tumor? We give yes. Can you just change your nicknames because TE, I don't know how to pronounce it. So T has got it correct. It is 4A. We usually give it 4A. The reason being it has a propensity to turn into a carcinoma. And secondly, we can downgrade it later on after biopsy. And these were breast siliconomas. So these appear as nodular lesions diffusely scattered of variable sizes and can or cannot be associated with skin thickening. Okay, how about this? It's a very classic appearance. You have to name the sign if possible. Yes, it's an intracapsular rupture, Rahul. It's Linguin sign. Very good. Also known as the wavy line sign. And it is a consequence of extensive intracapsular rupture. So, yeah. So now here we can see the Linguin sign as well as there is a T2 hyperintensity with some hypointensity. So it is basically fluid with air foci within, and this is known as the droplet sign. Okay, so it is also a consequence of intracapsular rupture and because of the fluid and gas within. This is the keyhole sign or noose sign. So it is giving an appearance of a noose, like what we call a tying of a lace, like that. This is also a consequence of intracapsular implant rupture. Okay, now who got this one right? We were talking about intracapsular ruptures so far, and now we can see something outside the implant. So this is a extracapsular rupture. So the only idea of putting this spotter is that every time you should not just focus on the intracapsular. There can be something like an extracapsular over here. It is. And there was one 13B also. What do you think this is? Is it pathological or it can be found normally? So not every time it has to be pathological. This is just a radial fold. And as of now, there is no capsular rupture. So this is a normal finding which we can see commonly. Okay, so fat necrosis of the breast. See, in this case, we have a late phase of the fat necrosis because we can see calcification of its wall and there is debris within. So you should know how a fat necrosis appears in acute phase and subacute phase and late phase. This is a very commonly mistaken spotter. So you have to be acquainted with all the three phases. So this was a simple one. It's a lipoma, right? In the right breast, you can see. Okay, so these were the spotters. Now we'll move on to the section B, which will majorly contain the fluoroscopic images. This is the first spotter here, spotter number 16. You can just jot down the answers right now. We can discuss it later on together. I'm giving you 20 to 30 seconds for each spotter. Number 17, spotter number 18, number 19, number 20, the endometrial cavity is also irregular here. So 21, the 21 has one more image. This is the HSG image. I'll give you the ultrasound as well. That will fetch your diagnosis very easily. Twenty-two, 'I can give you a hint. It's a male patient. 23, So that filling defect in the endometrial cavity is actually it's a filling defect. It's not a pathology because of the contrast. Endometrial polyp would have been well defined. Is it looking well defined? Now next photo 24A. And 24B. So now here you can delineate that thing, right? In the previous image, it was a filling defect of the contrast. Twenty-five. Most of you are getting it correct. 26. 27. 28. An easy one. 29. So zoom, is it inside the uterus or outside the uterus? 30. So this is an MRI image of the same ultrasound image. Yeah, IUD is there, but what is the pathology? 31. So it is a systemic condition caused due to pelvic pathology. One of the syndromes, yes, few of you are getting it right. Akshay, great zone, right? Okay, so we'll come to the answers. What do you think this was? I think few of you have got it correct because does it look like a T-shaped T-shaped uterus? Now, Rahul, why isn't it SIN, salpingitis systemica nodosa? The reason being it is just not a well-formed uterus. It is looking so constricted and there's a typical T-shaped appearance. Can you appreciate that? And of course, it is irregular, nodular kind of, but the shape itself, it is very pathognomonic for diethyl diethylstilbestrol exposed uterus, okay, which is a T-shaped uterus. Adenomyosis and this, why would it be? Like it is a typical T-shaped. There's no chance of adenomyosis. SIN could have been a closer differential, but still. How about this? 17th. Yeah, most of you have got it correct. It is a arcuate uterus. Okay, now how much is the fundal dipping and intercornual distance? When do we call it bicornuate? First of all, looking at the external fundus, fundal contour, and then, yes, septate has a degree of 90 degree or less, bicornuate more than 105 SS, you're correct. And even the intercornual distance in the bicornuate uterus is more. It can be more than 2.5 to 3 centimeter. So you need to know the basic difference between bicornuate and septate uterus. Yeah, I'll use a pointer. Okay, so this is the external indentation on the external fundal region. And then the intercornual distance, this, if it is more than 3 centimeters, and if we put a perpendicular till the dip of the endometrium, and this should be more than 1.5 centimeter. Intercornual distance more than 3 centimeter, and the angle more than 105. So we call it bicornuate. Okay, you need to be well versed with this. Escher classification also, you have to learn it by heart. So what is this? Now, few of you have got this right. Is it pathological or I think none of you got it right. See here you can see some extravasation of contrast in the through the vessels, right? So it is intravasation of contrast in the vessels or lymphatics can be there. In this case, there is contrast is going into the right internal iliac vein. So it is venous intravasation. So these are all vessels which are seen. Okay, these are not fallopian tubes. Fallopian tube is over here and this is the other one, but these are the vessels. So this such kind of spotters can also come. This is intravasation on HSG. And why you have to be vigilant about this? Because there is a propensity for contrast allergic reaction in this case. Okay, so and most commonly it happens when the tubes are blocked. So rather than going into the free flow of the contrast into the pelvic cavity, it is going somewhere else. It is It is extending through the lymphatics or the venous channels. So most of you have got this one correct, and this is SIN, salpingitis ischemica nodosa. So that these are like dilated, tortuous fallopian tubes bilateral, which are occluded. They are not patent, how we can say, because there is no free spillage of the contrast. Moreover, there are multiple diverticula. The uterine cavities appearing irregular. Okay, so these two things. Had it been just about the fallopian tube, we could have called it obstructed hydrosalpinx. But look at the endometrial cavity. It is also looking irregular, right? So it is pathology involving the endometrial cavity as well as the fallopian tubes, which is typical of SIN. Okay, so another case here also there is irregularity. These are obstructed fallopian tubes. Okay, how about this? Here you can see the endometrial cavity, it is appearing smooth, right? And how about the fallopian tube? It is dilated. So this is hydrosalpinx, right? Rahul, you're correct. Left hydrosalpinx. Can you please explain points in detail where you show us the answer slide? Okay, okay, fine. But that will take a lot of time. We won't be able to cover up the things. That's why I'm just focusing on the main points. So when you call it hydrosalpinx, it should be more than 4 mm in diameter. Okay, you should know the common causes. Yeah, Zoom, I'll do that. Common causes of PID, tumor, etc. And we are well versed with, cystic convoluted appearance, incomplete septations, all these common things I won't be discussing. Okay, so this was an interesting one. This is not, it was a male patient, so there is no question of HSG in this patient. It was a herniagram basically, and this is a case of patent processus vaginalis. So you can see this is a patent processus vaginalis, and we have given the contrast to the hernial sac. Okay, what is a processus vaginalis? It is a peritoneal diverticulum which envelops the fetal gonads as they descend from abdomen into pelvis. It is attached to gubernaculum and part persists as tunica vaginalis. Okay. When patent, it permits intraperitoneal connection to the scrotum. It extends totally into the scrotum. So here we can see it is extending from the abdominal cavity up to the scrotum. So please be careful with this spotter. Don't be. And few of you have called it as ruptured bladder and all. Actually, the contrast is extravasating into the bladder, but it is not ruptured. There are no signs of rupture, right? Okay, so in this case, many of you have called it endometrial polyp, but see, this is not a very well-defined thing. It is more so because of some air locule must have come. Because of that, there is a filling defect. But you can see the fallopian tubes, they are being pulled apart. They are going towards laterally towards the pelvic wall. So there are certain kind of adhesions which are forming with the fallopian tube. So and and there is also spillage of contrast. So I guess the left one is patent, the right one also shows some spillage. So both the fallopian tubes are patent, but they are not in the normal location. They are displaced. See, one is here and the other is fine, but they are somewhat laterally. So this is a case of Asherman syndromes, and there are multiple adhesions in the pelvic cavity which is causing this. So most of you got this correct. This is a polyp, endometrial polyp. Here we can see this is a well-defined filling defect. This is also an endometrial polyp, right? Okay, so the closest differential is submucosal fibroid, sessile. or pedunculated, any of those. Okay, so this is a typical banana-shaped unicornuate uterus, right? So only one cornua we are seeing, which is towards the left. And mostly it happens that the right one is absent and left is patent. Okay, and this also most of you have got it correct. This is a bicornuate uterus and there is gestational sac along with decidual reaction in the on the right side. Correct. On the left side, sorry. Yeah. Okay, so this is a cyst. Everybody has picked it up. There is a cystic lesion in the anterolateral aspect of the vagina. So what is it? It's a Gartner duct cyst, right? So what is the common differential of this? Bartholin gland cyst, where is it located? It is in the posterior wall. Posterolaterally is Bartholin's and anterolaterally is Gartner. You have to remember this thing. And whenever we come up with a case of Gartner duct cyst, so we have to look up for any metanephric uterine anomalies. Okay, right from the kidney, we have to trace till the vagina, whether there is any renal agenesis, whether there is any renal dysplasia or any kind of cross-fused ectopia. And also we have to look for the ovaries, uterus, everything. So this is the ultrasound image and here we see on MRI. Nabothian cyst, very common. Everybody got it correct. Okay, so few of you called it as AVM, but actually the vascularity is around the paravesical region, right? So parauterine, paravesical region, it is outside. Right, right. Pelvic congestion syndrome. Very good. Okay, so why it happens? There is reflux in the ovarian veins. Because of that, there are pelvic varices. Okay. And this was, yes, IUD was there, but you can see the uterus is also looking bulky. It is quite, there is a fat stranding, there are some adhesions also. So this is a typical pelvic inflammatory disease. Here also we can see there is free fluid, there are adhesions and loculations. So you need to know the causes of pelvic inflammatory disease. Most commonly, it is secondary to the STDs or in case of pregnancy, when there is abortion, post-abortion and puerperal infection. And there can be secondary causes like diverticulitis, actinomycosis. In this case, it was secondary to this diverticulitis. No, it was, no, this is a loculated collection only. Okay. It can be primarily due to the pelvic condition. Yeah, most of you got this correct. It is a syndrome called as Fitz-Hughes-Curtis syndrome. Okay, what is it? It is also known as perihepatitis, right? And in what conditions do we get this pathology? What is most commonly associated with this? It is secondary to the pelvic inflammatory disease. Okay. There is involvement of there is inflammation of the liver capsule and the overlying peritoneum with adhesion formations. Very good. Now we move on to the next section, which is section C. Ma'am is 13, tubovarian abscess. 30th. Which one? Yeah, it can be a tubovarian abscess. We have labeled it as a tubovarian lesion along with all these adhesions. So yeah, it can be the PID could be secondary to the tubovarian abscess. Very good. NK iPad. Okay. So the section C, mainly we'll talk about the ovarian pathologies here. So Number 32, very simple spotter. I'll swap it because everybody is getting it correct. 33. Okay. So actually the uterus, it's not a midline section. I guess the uterus has been displaced by this. It's a ovary. 34. It is uterus. Now, why would it be corpus luteal cyst? 35. So, yeah, now I think you'll get it correct. The same one, 35. 36. 37. Why can't it be like, is it a well-defined lesion to call it a fibroid? Like at few places you can see it is irregular, right? It's not that well circumscribed like a fibroid. And how would a fibroid be? Will it be hyper or hypo? So these are CT images of the same. This was MRI and this is CT. Thirty-eight. Yes, most of you are getting it correct. Right. Very typical appearance. Yeah. Dr. Rekha. 39. It's a ovarian pathology. Yes. TE has got it correct. Rahul, Bhagya, Del, Prateek, most of you. The ultrasound image. Potty. Del, why are you calling it adenomyosis? Is it inside the uterus or outside? Ovaries, can you see the ovaries? Yeah, Dr. Rekha, you've got it correct. Very good. 41. Awesome. iPad, Adya, Akshay. Very good. Great. Del also got it correct. You should write down your names, otherwise, all this Del and all, I don't know who these are. Prateet is correct. Yeah. By the way, Prateet, you are calling it Wunderlich. So there is one Wunderlich syndrome also, and there is one Herlin, like Ovira we call Herlin-Werner Wunderlich syndrome. And there is another called Wunderlich. That is a different I think that is post-traumatic or something. So you have to name it correctly, the complete name. Rekha, you're correct. Okay, so let's come to the answers. Very simple string of Pearl's appearance. So this was a enlarged edematous ovary with peripherally arranged follicles. What is it? It's ovarian torsion. Yes, Rahul, correct. Okay, now this one, somebody called it, like, you guessed it correct, that it's a uterine pathology, and somebody called it ACUM. What is ACUM? ACUM. ACUM is an accessory cavitated uterine mass, but that will appear as a uterus, but it will show no connection with the uterus. Now, this is a part of the uterus only. So, this is not ACUM. So, it is something very atypical. It's called the Robert's uterus. So, it is a variant of the septate uterus. So, here you can see the cervical canal is connecting with this cavity, and this is an obstructed thing. Okay, you can see asymmetric uterine cavities. This one is obstructed. I guess most of you can appreciate this. Why is it not unicornuate uterus with? So how is a unicornuate? We have seen earlier, right? It was a banana shaped and with collection and non-communication. So this is actually communicating. It has been obstructed, but it is not completely out. We could have given it one differential we can consider. I guess we can consider it as unicornuate as well, but it came out as it is a septate variant. Okay, I think this is not a very typical image. We'll have to take another image because, yeah, even I agree with you, Anup, that even unicornuate with a non-communicating rudimentary horn, which is obstructed, could have been like this. But you have to keep one differential in mind, that is Robert's uterus. Okay. Okay, most of you got it correct. This is a cobweb appearance in hemorrhagic cyst. So one thing you have to keep in mind is how to differentiate endometrioma and hemorrhagic cyst. Anybody? Okay, on MRI, we see the T2 shading and all. On ultrasound, we see very low level echoes in case of endometrioma, right? And of course, there are few cases in which we are just not very definite on either ultrasound or MRI, and then we have to follow it up. We have to compare the sizes. The one which is resolving is the hemorrhagic cyst, but endometrioma will not. Yeah, even the hemosiderin rim will be there in endometrioma. Very good. Low level hemosiderin. Okay, so these are the cases. And okay, this is a typical appearance of a GTN, molar pregnancy. Very good. So one more differential, it can be a differential for a thickened cystic endometrium also, right? So what are the differentials for that? It can be tamoxifen induced. It can be secondary to cystic hyperplasia or polyp. So these differentials also we have to keep in mind. One of the thing is that usually see this thing like GTN will come with mul bulky cystic ovaries also. That can be one of the points. It can be associated with bilateral theca luteal cyst. So that can be one indirect sign to differentiate it from other cystic endometrial stripe differentials. So like in this case, we can hardly say whether this is due to tamoxifen-induced cystic endometrial thickening or it is early changes of molar. And it is looking more or seems similar, but like you can look for the theca lutein cyst in case of GTD. Okay, this was also a case of molar pregnancy. Few people were calling it as fibroid and all. See, in CT, it can look like a fibroid, but in MRI, it was very much like there were cystic spaces. It was invading into the myometrium at few places. So it is a molar pregnancy. Okay, this is a typical for dermoid, right? Most of you got this correct. Zoom, which one you're calling as not C endometrium? Okay, we'll come up with that later. I don't know which one you're calling. The molar one. There were cystic spaces on MRI. Did you see that? There were cystic spaces typical of the molar grape structure appearance. Okay, so this is a mucinous ovarian cystadenoma. Okay. On we can very well see or the mucinous echoes on ultrasound. Okay, you have to be well versed with the FIGO staging. And this was a ovarian fibrothecoma. Okay, ovaries we cannot see properly. It is away from the uterus. There is no point of even calling it a subserosal fibroid because it is not arising from the uterus, right? It is just abutting the uterus and it is a solid appearing adnexal lesion. And the most common differential would be ovarian fibrothecoma. And the last, most of you got it correct. So here we are seeing a uterine diadelphys, right? This is an obstructed vaginal cavity. Here we can see, and this is another one. Here we can see the other one. And there is renal agenesis also associated. So this is a typical of the Ovira syndrome. All right, should we move to the next one? You have to read about this Ovira syndrome, read by heart. Okay, these were the cases. Now we move to the next section. I'll be a bit faster now. Section D. Okay, the quarter number 42. 43. There's one more image in 43. 44, a very easy one. So one thing which we were discussing earlier, the Ovira, which we call Hurlin-Werner Wunderlich syndrome, right? And somebody called it Wunderlich syndrome. So Wunderlich syndrome is different, okay? It is a condition where there is subcapsular rupture, perirenal rupture, and there is subcapsular hematoma. And it is non-traumatic most of the time. So you have to be careful while calling Ovira as Wunderlich. Yeah, fibroids. 45. 45. Yes, most of you are getting it correct. So now the prominent vessels, the vessels which are dilated and tortuous, they are within the uterus, right? So earlier they were outside, so we called it pelvic congestion. And in this case, they are within the uterus, AVM, correct. 46. Zone, you're correct. So, Bhagya, it is not predominantly soft tissue, right? It's more of cystic. So you can think of something less aggressive in this case. One more image for the same. Okay, one more. Yes, all of you are getting it correct. Very nice. 47, an easy one. 48. Yes, Govind Raj, you got it correct. Tamil Selvan, you also got it correct. Samsung, right. Apurva, right. 49. Think about it. So in the fluoroscopic images, one image was of herniagram, if you remember, something related to that. That was a male patient, and here it's a it's a male or female. What do you think? Yeah, it's a female now. Yeah, it's a hernia, but is it extending up into the pelvis? Up to the pelvis? 50th, you have to name the syndrome. Apurva, correct. Radio, right. Tamil, correct. Kabalan, Kabilan. Kabilan is also correct. Yeah, Bhagya, right. Rahul, correct. Okay, 51. Brief history. Primary amenorrhea with lower abdominal pain. Yeah, Tamil. You are quite close, but can you see a can you see the vaginal canal properly? Had it been there, then it could have been the option. Yeah, hematometra is there, but why is it happening? Yes, Bhavya, you're correct. Vaginal atresia secondary to what? Right. Okay. So answers, most of you got this correct. This is endometrial hyperplasia. And now this was a confusing slide, but after giving the MRI image, most of you got it correct. It is uterine adenomyosis. Very good. Most of you got this correct. Even with the figure staging you have come up. Uterine leiomyomas. All these. So can we actually differentiate leiomyosarcoma from leiomyoma to some extent, right? Like if it has some irregular walls, heterogeneity and all that, but not always. Okay, so this was AVM, and earlier images where we saw that pelvic congestion syndrome, the vessels which were dilatory were outside the uterus. Now you can see the vessels which are traversing within the myometrium. So this is AV malformation, uterine. Okay, so now why this is not CA and this is something benign? Obviously, the soft tissue is very less here. It is mostly cystic. So this is a condition known as adenoma malignum, which is a precursor, right? There is minimal deviation carcinoma. It is a precursor sort of a thing. And there can be some increased vascularity on color Doppler. And on MRI, it will appear multicystic lesion of variable size, some solid portions interspersed with it. So it gives a grape-like appearance on ultrasound because of the cystic spaces. So this is carcinoma cervix. Although it is a bit well defined for a carcinoma, it can be like somebody also called it as cervical fibroid. So I agree upon it. This could have been a cervical fibroid also because it is quite well defined. But again, it is no, it is not cystic. Why would you call it? Is it looking cystic? It is solid. It can't be a infected Nevotian. Okay, so you need to read about the figure staging of cervical carcinoma as well. And few of you got this correct. It is a vesico-vaginal fistula. You can see air inside this uterine cavity. So it is obviously an abnormal thing and it is coming from the bladder, right? So it is a VVF, vesico-vaginal fistula. Okay, so this thing, this spotter, somehow nobody got it correct, but yeah, I'm sure next time you will get it right. It is canal of Nuck herniation. So what we read about that patent processes vaginalis in males, it is a female counterpart called as canal of Nuck herniation. Okay, so here also there is a normal patent pouch of parietal peritoneum which is extending from the round ligament anteriorly into the pelvic region, and it may extend till the labia majora also. So this is a female counterpart of patent processes vaginalis in males. Okay, got it? Keep this in mind. This is a very typical spotter. Okay, May-Thurner syndrome, most of you got it correct and you have to get it correct. This is a very classic spotter. And what is it actually? It is a vascular compression syndrome, right? What happens is there is compression of the left common iliac vein, most likely by the right common iliac artery. So that's why the patient may come up with unilateral cellulitis of the left limb or pain in the left lower limb, like that. Okay, so there is vaginal atresia. So it can be secondary to the transverse vaginal septum also, or some of you call this as imperforate hymen, but in case of imperforate hymen, there wouldn't have been any vaginal atresia. We are hardly seeing any vaginal uh, cavity over here, right? And because of the vaginal atresia, there is hematocolpos. So don't call it imperforate hymen. It is vaginal atresia with transverse vaginal septum, with or without. So these are the answers. And now we move on to the last section, and we'll go a bit faster now. 52. So let's be quick. I want the answers. See, ovaries you are seeing on the actual image. Can you see the uterus? Very good, iPad. Yes, very good, all of you. So not always the images have to be very apt. You know, sometimes you have to look through, because I think these images are not that good. But still, if you can pick up the ovaries and absence of uterus, you come up with a diagnosis. 53. It is well marked. Deepak, you got it right. Govindraj, correct. Ishrat, Ishrat is also correct. 54. There is a ascites, there is skin thickening. Yes, very good. Most of you are getting it correct. How about this? 55. Very good. Most of you are getting correct. An easy spot of 56. Come on, tell the sign quickly, one of you. Very good. 57. What do you think this is? Around the fetus. 57. Apurva, very good. Apurva Thakre. Yes, Bhagya. Yes, all of you. Govind Raj, Zoom, and 58. Just see at what level is it? Is it at the abdominal cavity or at the level of uterus? Okay, 59. Tamil, now you got it correct. The previous one. Yes, iPad, you're correct. Please put up your real names. iPad, Samsung. Mhm. 60. Easy one. 60 pound. 62. 62. What about this? Yes, SS, you're correct. But apart from that, Govindraj, what is PAS? I don't know. Can you tell me the full form? It is completely covering the ors, right? Yeah, Rashmi, you're absolutely correct. But no, it's not actually. Is it invading the bladder wall completely? In axial, you can see. So what it would be? In axial, you see it is extending and in fact going into the bladder cavity. 63, just three more left. 63. Yes, Govindraj, absolutely correct. Tamil, why is it a lake? Just look at the vascularity. It's not a lake, no? It's vascular. 64. It's Tamil, very good. Very good. No, maybe Samsung in this image it is appearing single, but I think there are triple vessels. 65. Very good. Tamil, Govindraj, iPad, SS, Samsung, all correct. This is the last quarter for the day. An easy one. Mm. Mhm. Okay. Yes, correct. So there was one more spotter before this, no? Where there was some cystic outpouching. Now this is at the abdominal level. That was at the level of bladder. Okay, we'll come with that. Yeah, most of you are correct. Now we'll discuss the answers. MRKH. So there is no uterus, there is no cervix, but we can see bilateral ovaries. So this is Rokitansky syndrome. And what is the role of upper abdominal screening in this pathology? It is usually associated with renal agenesis, right? Yes, very good. Next is, this was an abruptio placentae. Few of you had called it as retroplacental hematoma. So is it looking like fluidic or is it like a avascular soft tissue? It is a avascular crescentic structure of low echogenicity between the uterine wall and placenta. And it is quite heterogeneous to call it a hematoma, and it is not even like a fluid, right? Most of you got it correct. There is pleural effusion, there is skin thickening. So this is a case of gross hydros fetalis. Okay, so because of the ventriculomegaly, we can see the dangling choroid plexus. Most of you got this correct. Yeah. Yeah, so what I showed was the lambda sign, which is seen in DCDA, dichorionic diamniotic, where there are 4 layers. And here there are only 2 layers. So we see the T sign in case of MCDA. Okay, amniotic band syndrome also. Most of you got it correct. So yeah, I think this was quite confusing because most of you did not get it correct. Only 1 or 2 got it correct. So this is at the level of bladder. And then there is some cystic outpouching. This is a bladder extrophy rather than omphalocele. Because omphalocele should come at the level of umbilicus or some abdominal content should herniate. Here the bladder is herniating. Okay, theca lutein cyst. And we had discussed it is associated with gestational trophoblastic neoplasm. And uh, see, don't get confused with ovarian hyperstimulation syndrome because the stroma is not there, right? Ovarian hyperstimulation will have a stroma which would be rather echogenic and there will be multiple follicles of variable size. But here this is completely turning into cystic. And even in OHSs, there would be ascites accompanied. All these things will be there. Yeah, Samsung, you're correct. There is no ascites in case of theca lutein cyst. Okay, swelling sign, most of you got it correct. This is frog-like appearance of anencephaly. Okay, now so this placenta is all over from posterior to anterior, covering the os completely. So complete placenta previa is there for sure. But apart from this, it is invading into the bladder wall and extending up to the lumen, bladder lumen. So it is placenta percreta with complete placenta previa. Choriocarcinoma, Bhagya, why are you calling it choriocarcinoma? Well, this is a plain scan, like I could not show you the vascularity also. So you have to look for it in contrast scan, invasive and aggressive. Yeah. So we can think of it, but we require a contrast scan for that. Okay, now what was this? This was placental chorioangioma. Most of you got it correct. No, I think few of you only got it correct. So hypoechoic areas with internal vascularity is the key feature. That is how you differentiate it from placental lakes, right? Okay, and this also most of you got correct. This is velamentous cord insertion. Yeah, this was lumbosacral meningium, meningocele. And now this is midline herniation of the abdominal content. So this is omphalocele, right? It was midline and we can even see the membrane over this. So these are the two key features by which we differentiate it from gastrochiasis, where there would be paracentral or off midline location and there would be no membrane covering in case of gastrochiasis. So these are the key to the answer. Now we move on to the OSCE. So just briefly, I would tell you So what OSCE actually is? So OSCE is objective structured clinical examination. So objective means it asks you to be to the point. The answer should be crisp and precise. It should be structured. Like we should have a systematic approach which should focus only on the salient features. So, and it is a good practice to always describe like the obvious findings first. Okay. And then clinical means we have to correlate it clinically. We have to summarize it in one sentence, linking the images to the clinical scenarios. Fine. So this is the first OSCE. We have 10 OSCEs. I'll just give one minute for each so we can wind it up earlier. Okay, the questions are these. Now this is an OSCE radio. You have to answer the questions. It's better you just jot it down because it makes a lot of difference while you're writing it and just orally discussing. Because you should know what to write there. You have to be crisp and precise. So should we move to the answer? So these are the answers. So the typical MRI appearance of the endometrium, it is uniform, diffusely thickened with smooth margins, hyperintense on T2. Okay. Which hormonal imbalance most commonly implicate? So it is unopposed estrogen stimulation. And how can we differentiate benign from malignant transformation? Focal mass will be there, irregular junction interface between endomyometrium, restriction diffusion, very important point, and obvious invasion is a very obvious sign. Okay, so what are the associated clinical risk factors? So there can be obesity, PCOS, tamoxifen toxicity, estrogen replacement. Okay, and what are the treatment options in case of typical hyperplasia, where we are not suspecting anything to go malignant, just progestin therapy is applied. And then in case of atypical or complex, which is suspicious, directly go for hysterectomy. So when it comes to OSCE, right from the diagnosis till the treatment, you have to read everything because the questions are typically like this. It is asking you about the imaging appearances, then the related, what are the pathologies, how, the etiology and everything, and then associated risk factors and treatment, everything, right? Yeah, so it was endometrial hyperplasia. This is the second OSCE. So one thing you have to keep in mind that OSCEs are not about the very atypical diagnosis. It is just something very simple, just like this PCOS thing, right? But you have to know the ins and out. Yes, I'm giving the questions. Should we move to the answers? Please type done in the chat box once you're done with the answers. Akshay is done. Who else? Okay. So, okay, so what is the classic ultrasound sign? Everybody knows it's string of pearl's appearance. And criteria, yes, it should be more than 12 follicles. And the size should be 2 to 9 mm. Volume should be more than 10 cc. Usually we consider 12 cc and above, but 10 is also fine. So what are the underlying endocrine abnormalities? Chronic anovulation, hyperandrogenism, insulin resistance, right? Potential long-term metabolic complications could be due to type 2 diabetes, metabolic syndrome, cardiovascular risk, and endometrial carcinoma also it can cause. And how is infertility managed in such patients? Lifestyle modifications. You can just take a screenshot because such typical questions will be asked in very simple pathologies like PCOS and all.
Ma'am will be providing them the file, PDF
Okay,
file.
okay, okay. Fine, fine. Yeah. Okay, we'll move to the next third OSCE. Yeah. Hmm. Okay. Should we move to the questions? Let me know if you want to see the image again. Done with the answers? Five seconds more. Okay, I'll move to the answers now. So what stage it was? Stage one, confined to the cervix, not invading anywhere else. Okay, imaging modality. Which imaging modality is the preferred one? It is MRI, right? And what are the key radiological findings for endometrial invasion? Irregular tumor margins, disruption of low signal intensity stromal ring, parametrial strands, or mass. And what is the advanced imaging technique which is most useful for distant metastasis? Is PET. And main treatment approaches for diseases, radical hysterectomy with lymphadenectomy and chemoradiation depending on the stage. Fine. So it was cervical carcinoma stage 1B, figure staging. Yeah. Okay. Fourth Oscar questions. Done. Okay, so we'll discuss the answers. So, how do we differentiate carcinoma from benign lesions? So, we have to look for the stromal disruption. Okay, that is the telltale point. Next question is MRI sequence most useful for assessing the lymph nodes is contrast T1, PATSAT image, along with diffusion. You should always compare it with diffusion. Many times there are small lymph nodes which can be missed out even on contrast. So, we have to correlate it with the diffusion actual image. So what is the role of diffusion weighted imaging? When there is highly cellular tumor, it will show more and more restriction. So that is how it will help in evaluating. How does MRI help in assessing fertility preserving surgical options? So it assesses exact tumor size, depth of stromal invasion, parametrial status, crucial for considering fertility sparing tracherectomy. So what are the common routes of spread? So it can be lymphatic, hematogenous, or even local extension. Okay, fine. Okay, number 5, questions. Done. Okay. So the answers. So characteristic appearances, there is multicystic appearance where deep stromal involvement. Okay, so it is T2 hyperintense with stromal involvement. So, and how do we differentiate it from benign conditions such as benign cystic lesions? Benign cystic lesions would be more superficial. There won't be any deep stromal extension. Why can this condition be easily missed or underdiagnosed? Because it is usually cystic and it gives an appearance of being benign. It mimics benign pathology because of the predominantly cystic nature. And the cervical contour is also maintained. What is the histopathological subtype associated? Minimal deviation adenocarcinoma, that is adenoma malignum. Yeah. And what is the prognosis and typical management strategy? Prognosis is poor because there is deep stromal invasion. Okay, and the treatment will include radical hysterectomy with lymphadenectomy or plus or minus chemoradiation. Okay, so we're left with just four more spotters. Let's hurry up. Spotters now, ask you. Junctional zone is thickened with punctate high signal foci. Okay, the questions. Um, all right, so we'll come to the answers. Okay, what is the pathophysiological basis of junctional zone thickening? So there is basically smooth muscle hyperplasia and due to ectopic endometrial glandular infiltration, it leads to disruption of myometrial architecture. How does DWI and MR spectroscopy contribute? So DWI will represent high cellularity in case of adenomyosis and MR spectroscopy will show the altered choline peak, suggesting proliferative activity. In what ways can imaging biomarkers predict response to hormonal or interventional therapies? So, baseline junction zone thickness and ADC values correlate with treatment response. Thinner the junctional zone after therapy indicates regression and symptomatic improvement as well. How does adenomyosis impact fertility and role in advanced imaging play in guiding assisted reproductive technologies? Yeah, ART. So, adenomyosis causes abnormal uterine contractility, implantation failure, pregnancy loss. MRI mapping of the lesion extent helps select patient for ART. MRI mapping. Yeah, the extent of the lesion we have to tell basically. So discuss how artificial intelligence. So in this case, AI based radionomic extracts texture and uh, uh, perfusion features beyond visual perception, enabling improved differentiation from fibroids. Yeah, fine. Okay. Okay. Now the seventh one, infertility assessment, pacification extending to the right common iliac vein. Okay. The questions. Should we proceed for the answers? All right. Okay. So, what was the abnormal finding? There was venous intravasation of contrast, more so in the right iliac veins. So, what are the potential complications? So, there is a risk of oil embolism. There can be pelvic vein thrombosis, and even we can misinterpret with tubal patency. So, how does one differentiate contrast intravasation from intraperitoneal spillage of contrast? So, intravasation is mainly in the venous and lymphatic system, and intraperitoneal spillage would be free fluid seen around the in the pelvic cavity and around the bowel loops. So, what procedural factors increase the risk of this complication? So, high injection pressures, acute or chronic endometritis, recent curettage, obstruction of tubes, tubal blockage. How, the, how should the procedure be managed immediately upon detection of this abnormality? Immediate cessation of injection, first and foremost. Then close monitoring for embolic symptoms. For avoid further oil-based contrast use. All good. So let's move to the next, which is the eighth OSCE. These were all in the spotters, and now we are elaborating it in the form of OSCEs. Should I show the questions? tubes are patent with free spillage into the peritoneal cavity? These are the questions. Okay. Please type once it's done. Okay, let's move to the answers now. So, what histological changes underlie? So, histology shows diverticular herniation of endosalpinx into hypertrophied fibrotic muscularis due to chronic inflammation. And now, how to distinguish between tubercular and post-surgical changes. So tubercular salpingitis will give the typical irregular beaded tubes with strictures and calcifications, and it would be mainly bilateral. Whereas in surgical diverticula, it would be localized and it would be unilateral mostly, and it would be sharply marginated. There would be abrupt changes, right? How does this abnormality predispose specifically to ectopic pregnancy? So, because of the impaired ciliary action and gamete transport, which is caused secondary to distorted tubal lumen architecture, there would be nidations. Nidus would be created for ectopic implantation. Okay, so in case of contrast, HSG, MRI, and laparoscopy, what are the comparative roles of these? So, in case of real-time hysterosalpingography, it it is safer than normal HSG, and MRI will show mural nodularity and diverticula. Whereas laparoscopy, it is the gold standard. It cannot be replaced. There will be direct visualization, as we can see. We can see the tubal damage directly. Now, considering the poor natural conception rates in SIN. So, SIN is strongly linked with infertility and ectopic pregnancy. Okay, microsurgical repair has limited success. IVF bypasses tubal pathology and is preferred fertility option. Correct. Okay, let's move to the second last and then, okay, ninth. Okay, questions? Okay, we'll move to the answers. So, what is the characteristic sonographic appearance? Cobweb appearance, which is due to fibrine strands and clot retraction. So, how can you differentiate this from endometrioma and malignancy? So, endometrioma will show low-level homogeneous echoes, whereas in case of malignancy, there will be internal vascularity, there will be papillary projections, and at times solid nodules also. So, what are the typical temporal changes? So, over time, hemorrhagic cyst will regress and with clot liquefaction and resolution over 6 to 8 weeks, whereas endometrioma won't. So, what complications should be excluded on imaging in the acute clinical setting? Complications such as cyst rupture, we'll find free fluid in the pelvis, ovarian torsion, and hemoperitoneum. What is the standard management approach for this lesion? So conservative management with follow-up on ultrasound at a duration of 6 to 12 weeks and MRI if uncertain, surgery if persistent, enlarging and suspicious features. Okay, so the last ASCII for today. Histogram shows contrast opacifying the bladder with extravasation of contrast into the vaginal canal. Informing the communication. These are the questions. We can move to the answers. So So worldwide, what is the most common cause? It is obstetric trauma. And unfortunately, in the developed nations, it is iatrogenic. And what imaging modalities apart from conventional cystography? So we can do CT cystography, MR pelvis, MRI can be done, IV urography, and transvaginal ultrasound with contrast. So what are the characteristic MRI findings? MRI findings on mainly T2 is important. T2 weighted image will show a tract between the bladder and the anterior vaginal wall with surrounding inflammatory changes, and even contrast is important in delineating the tract. So how does the timing of surgical repair affect? So early repair, risk failure due to inflammation, delayed repair after tissue healing is preferred. Alternatives are transvaginal repair, laparoscopic, robotic repair, interposition grafts, uterine diversion in refractory cases, etc. So I hope you got a somewhat a brief
idea of how to approach the cases, OSCE cases, and as well as the spotters. And I tried to cover a lot of spectrum, right from the fetal case, imaging cases, breast images, and hysterosalpingography. So, any questions you want? You want to ask any questions, any of you?
You can write your questions in the chat box. I think, ma'am, if there are no questions, then we can close this session. Thank you, ma'am, for this extremely wonderful session, and you clarified all the doubts of the residents throughout. And I hope that residents will be less panicky in the exam, will be able to identify spotters and the images in a better way, and also the able to identify the images in the OSCE. And my only advice to the residents is that whether it is about practicals or you go out in real practice after your exam, the idea of the radiology is to identify the images. Our branch is a visual branch. We are not, if we cannot identify the image, then we cannot move to the diagnosis, or at
Yeah.
least at least to a differential diagnosis.
Yeah,
So
and secondly, you should not try to be a perfectionist. Don't look for the big diagnosis. Focus on the basic things because that's where you lose the marks. If you blunder up on the basic questions, the commoner ones, that's where you lose the race, right? So
yes, ma'am.
I have tried to cover all the basic questions, basic spotters, and even the OSCEs were quite basic. So
Yes,
focus
ma'am.
on the basic spotters rather than going after the major atypical
Yes,
thing.
ma'am. And also, I would like to say, at least try to practice 5 to 10 new images from your textbook and all the PPT files and on only WhatsApp groups, whatever you are comfortable with. Just try to see new images every day and sensitize your brain to become familiarized with the various spectrum of the diseases which are being diagnosed every day. Go through the journals, go to, look at the research paper. Just look at few images every day, and over a period of time, you will have a wide library of images in your mind, so that you will be able to pick up in the real practice more and more diagnosis, and your journey will be a much smoother one. So we'll be continuing with these sessions from tomorrow onwards, and at the same time. So
Yeah.
I think
And I think Chandrakala has said that some more detailed explanation needed. So we can discuss few of the cases, but since this was a spotter session and OSCE session, we had to cover major things. The spotters had to be covered. So uh, don't focus on the explanation. It was more about the visual thing, like covering the spotters mainly.
yeah, for where we planned for some case discussion series also will be after this session. We will be doing that, so don't worry about that. So this is basically to give you an idea about the spotters and the how the OSCEs are, especially for DNB candidates, how the OSCEs are conducted, what kind of questions are asked. It is not only the diagnosis they will ask in the in the main exam. You have to read little bit about the disease and this management part and its syndromic associations in many cases. So if and for to reaching to that point, you have to first identify the image. If you're not able to identify the image, then you will not be able to answer at least 3 or 4 questions from that image. So better practice more and more images every day so that you are able to answer the OSCEs also in a better way. So I think that is for all today. Again, thank you very much, ma'am, for this session. So I will be concluding this session right now. And tomorrow we have musculoskeletal. So we'll be sharing the PDF of this in the group tomorrow as well as the recording, those who have missed. So good night, everyone.